She has slept on her right side for as long as she can remember. The same position, the same pillow arrangement, the same arm tucked underneath. It is as much a part of her as anything else in her life. She sleeps well, mostly. She wakes feeling a little unrested some mornings, but she attributes that to age. What she has never been told, because it has never come up, is that the position she has been sleeping in for decades may be placing a quiet and steady burden on her heart through every hour of every night. Sleep position is one of the most overlooked variables in cardiovascular and respiratory health, particularly for adults over 60. A routine checkup covers blood pressure, cholesterol, heart rate, and medication adherence. It almost never covers how you are oriented while unconscious for 7 or 8 hours each night, and yet the position of the body during sleep directly affects the mechanical load on the heart, the efficiency of the lungs, the clearance of fluid from the airways, the drainage of lymphatic and venous systems, and the frequency and severity of airway obstruction. These are not subtle effects accumulated over a single night. Over years and decades, the nightly position shapes outcomes in ways that are now supported by a meaningful body of cardiovascular and sleep medicine research. My name is Dr. Evan Noris. I am a cardiologist with 22 years of clinical experience, with a particular focus on sleep-related cardiovascular health in adults over 60. What motivated this video is how rarely this conversation happens before a patient already has a diagnosis that makes position matters urgent. After 60, the cardiovascular system operates under a set of conditions that make sleep position more consequential than it was at 40. The heart muscle may carry the early signs of decades of pressure work. The arteries are less elastic. The lymphatic system drains more slowly. The airway muscles lose tone, making obstruction during sleep more likely. And the fluid that accumulates in the lower body during the day, in the legs, ankles, and feet, redistributes toward the chest and heart when the body goes horizontal, increasing the volume the heart must manage through the night. Think of lying down as pulling a plug on the daytime distribution. Everything that gravity held in the legs now flows back toward the central circulation and the heart. In a healthy system at 40, this redistribution is managed smoothly. After 60, when the heart may already be working near its comfortable capacity and the lungs have less reserve, the position in which the body lies during this nightly fluid redistribution changes how well the heart tolerates it, hour after hour, for the rest of a person's life. Before I walk through what the research tells us about the 5 most important sleep position considerations for adults over 60, I want to ask you something simple. What position do you typically fall asleep in? Back, left side, right side, or stomach? Just type it in the comments. I am genuinely curious what this community's default is. The first sleep position consideration I want to address is sleeping flat on the back, supine sleep, for anyone who snores or who has been told they may have sleep apnea, or who regularly wakes with a dry mouth or unrefreshed feeling. When the body lies flat on its back, the tongue and soft palate fall backward under gravity toward the posterior pharynx, narrowing the airway. The throat muscles, which lose tone with age just as other muscles do, provide less resistance to this gravitational pull. The result is partial or complete airway obstruction during sleep, what we call obstructive sleep apnea, which produces repeated arousals, oxygen desaturation, and repeated surges of adrenaline and cortisol through the night as the body repeatedly works to reopen the airway. Each arousal produces a brief spike in blood pressure and heart rate. Over hundreds of arousals per night, 7 nights a week, 52 weeks a year. This is not a minor cardiac burden. Research published in the Journal of the American College of Cardiology and other journals has documented the association between obstructive sleep apnea and increased risk of atrial fibrillation, heart failure, and coronary artery disease. A man named Cornelius, a former harbor dockmaster who was known for his physical resilience and who had always dismissed his snoring as a personality characteristic rather than a health concern, came to see me after his wife recorded him on her phone during the night, not to embarrass him, but because she was frightened by what she heard. The recording showed prolonged periods of silence between snoring bursts, each followed by a gasp. He had been sleeping on his back for decades. A sleep study confirmed moderate to severe obstructive sleep apnea. The practical fix: if you snore, wake unrefreshed, or have been told your breathing is irregular during sleep, raise it with your doctor and ask about a sleep study. Position alone, switching from back to side, reduces apnea severity in a meaningful proportion of patients, though many also benefit from additional treatment. The second consideration is sleeping on the right side specifically, a position that many people find comfortable and that has a specific cardiovascular effect that is worth understanding. When the body lies on the right side, the heart shifts slightly within the chest cavity, and the weight of the surrounding structures places the apex of the heart in a position of greater mechanical compression. More significantly, the stomach, when full or even partially full, presses against the diaphragm on the right side position in a way that can reduce diaphragmatic excursion, meaning the diaphragm cannot descend as fully on each breath. For people with any degree of heart failure or reduced left ventricular function, the right side position has been associated in clinical observation and in research from sleep medicine with increased nighttime symptoms, including breathlessness, coughing, and orthopnea, the sensation of breathlessness when lying flat. The left side position, by contrast, allows the heart more natural mechanical room and is generally considered the more heart-supportive default position for adults with any cardiac history. A woman named Winifred, a former textile weaver who had worked at a loom for 40 years and who had always slept on her right side because that was how her body had simply always arranged itself, came to see me after a period of waking in the night feeling vaguely breathless. She had been diagnosed with mild left ventricular dysfunction 2 years earlier and had been managing it well. When I asked about her sleep position, she said right side, without hesitation. She had never been told it mattered. Transitioning to left side sleep, which she accomplished with a body pillow that made it easier to maintain, eliminated the nighttime breathlessness within 2 weeks. The practical fix. If you have any history of heart disease, heart failure, or left ventricular dysfunction, discuss your sleep position specifically with your cardiologist. Left side sleep is generally the more heart-supportive position, and the change is straightforward to make with the right pillow support. The third consideration involves sleeping flat, without any head or upper body elevation, and specifically the fluid redistribution effect I described in the biology section. When the body goes horizontal, venous blood and lymphatic fluid that is pooled in the legs and lower body throughout the day flows back into the central circulation. For the heart, this means a higher fluid volume arriving during the hours of sleep, a condition called increased preload, which requires the heart to work harder to manage. In people with healthy cardiac function and no history of heart failure or hypertension, this is well tolerated. But for adults over 60 with any degree of reduced cardiac reserve, elevated blood pressure, or early heart failure, this nightly fluid return can produce worsening breathlessness, coughing, and disrupted sleep, particularly in the first 2 to 3 hours after lying down. Sleeping with the head and upper body slightly elevated, by as little as 15 to 30 degrees, reduces the rate and volume of this fluid return to the chest and allows the heart to manage the redistribution more gradually. Research in heart failure management consistently supports head-of-bed elevation as a non-pharmacological intervention for reducing nighttime cardiac symptoms. A man named Leopold, a former instrument maker of extraordinary precision, who had never been comfortable unless his environment was perfectly arranged, came to see me frustrated that he woke consistently at 2 in the morning with a dry cough that resolved when he sat up. He had heart failure that was well controlled by medication during the day, but his bed was completely flat. Elevating the head of the bed by 20 degrees, achieved with a wedge pillow, eliminated the 2 o'clock cough within a week. The practical fix. If you regularly wake with breathlessness or coughing that improves when you sit up, discuss head-of-bed elevation with your doctor. A wedge pillow is an inexpensive, non-medical adjustment that can meaningfully reduce nighttime cardiac strain. If you are still with me and finding this useful, type the word sleep in the comments right now. It helps me understand who this conversation is reaching. The fourth consideration involves stomach sleeping, a position that a surprising number of adults maintain well into later decades, despite the mechanical problems it creates. When the body lies prone, face and chest down, the entire weight of the torso presses against the lungs and heart, compressing the thoracic cavity and reducing the space available for cardiac and pulmonary expansion. The neck must rotate to one side to breathe, placing sustained torsional stress on the cervical spine, and the arterial structures within it, including the vertebral arteries that supply blood to the brainstem. After 60, when the cervical discs have lost height and the vertebral arteries may carry some degree of atherosclerotic change, sustained rotation during hours of sleep is not benign. Additionally, the prone position eliminates the ability to use any of the positional adjustments, side preference, head elevation, leg positioning, that are available to side and back sleepers. It is the position of least flexibility for cardiovascular management. A woman named Isolde, a former marine archaeologist who had spent decades sleeping in cramped quarters in the field and who had adopted stomach sleeping as the only position that felt normal, came to see me with persistent neck stiffness that she had attributed entirely to her fieldwork. When I asked how she slept, and she described stomach sleeping with her head rotated to the right, I noted that the stiffness was consistently on the left side, exactly the side the neck was being stretched toward all night. Transitioning her, with significant pillow support on both sides and a deliberate effort over several weeks, to a side position, resolved the neck issue, and also improved a pattern of morning grogginess she had assumed was simply age. The practical fix: if you are a stomach sleeper, begin working with a physical therapist or sleep specialist to transition to a side position gradually. It takes time and the right pillow arrangement, but the cardiac and cervical benefit is worth the adjustment period. The fifth consideration is the least commonly discussed and may be the most practically impactful for people who do not have significant cardiovascular disease, and that is the position of the legs and lower body during sleep in relation to fluid accumulation and overnight cardiac load. Many people sleep with their legs flat or even slightly lowered relative to the rest of the body, sometimes because the mattress has compressed unevenly, sometimes because they prefer that orientation. When the legs are flat or lowered, the venous return of fluid from the lower body to the central circulation is maximized. More fluid returns to the heart and lungs during the night. When the legs are slightly elevated, even by a few inches, venous return is gently reduced, the overnight fluid redistribution is moderated, and the heart has a smaller volume to manage. For adults over 60 with mild lower limb edema, mild heart failure, or chronic venous insufficiency, this simple positional adjustment can reduce overnight breathlessness and morning ankle swelling. A man named Alistair, a former civil aviation inspector who approached every problem with careful, methodical analysis, had been sleeping in a bed where the foot end had sagged several inches over years of use, meaning his legs were actually slightly lower than his torso through the night. He was waking with swollen ankles and feeling more breathless in the morning than in the afternoon. The cause was partially postural. Placing a folded blanket beneath the foot of the mattress to level the surface, and adding a thin pillow beneath his lower legs, reduced his morning swelling meaningfully within 3 weeks. The practical fix: if you experience morning ankle swelling or increased breathlessness upon waking, check the levelness of your mattress and consider whether a thin pillow beneath the lower legs might moderate overnight fluid redistribution. Discuss this with your doctor in the context of your cardiovascular history. Here is what I want to leave you with, and I want to say it as directly and personally as I can. Tonight, before you get into bed, I want you to think about what position you are about to spend the next 7 or 8 hours in, and whether anyone has ever asked you that question before. If you snore or wake feeling unrefreshed, raise the possibility of a sleep study with your doctor. If you have any cardiac history, consider whether left side sleep and head of bed elevation are appropriate for your situation. If you are a stomach sleeper, begin the slow work of transitioning. It is not something that changes in a week, but it is worth starting. Look at the levelness of your mattress and your leg position. And if you regularly wake in the night with breathlessness or coughing that improves when you sit up, bring that symptom to your cardiologist as a priority. Sleep is not passive. It is 7 hours of either protecting or straining a cardiovascular system that carries everything else you do. Everything I have shared today is meant to open a conversation with your physician, not to replace one. Your specific cardiac history, your medications, and your individual anatomy all shape which of these adjustments is right for you. Please bring these questions to your doctor. They are the right partner for this conversation, and it is one worth having sooner rather than later. And if thinking about what your cardiovascular system is experiencing during those 7 or 8 hours has you curious about what else is affecting heart health while you sleep, The next topic I want to walk you through is the connection between sleep quality, cortisol, and blood sugar regulation overnight, and what you can do to shift that relationship in a healthier direction.